Session started. I'm Alison Hall, and I'm one of your moderators, along with my co-moderator here, Bill Lombardi. And I'm going to welcome our wonderful panel today. So we've got Darshan, Doshi, and Kearney here. And we've got Salman, Allana on the other side, and Jason Wollmuth. And it's Ankur, Gupta on the other side there as well. Welcome, everybody. So our first speaker today is going to be Lorenzo Azzalini, and he's going to give us a year in review on CTO publications.
All right, thanks, Alison. I don't know where I'm supposed to be standing, but all right. Okay. So these are my disclosures. There's really a lot to talk about. In the last few months, there's been a lot of activity in the CTO-PCI field. So my talk is divided in this 4 sections. Let's start with outcome data. Most of these papers here are coming from the Progress CTO registry. This is a paper on in-hospital outcomes and temporal trends of CTO-PCI. We're seeing that the anatomic complexity, more or less, and crossing strategy remain the same over the past few years. There is a more tendency towards using more the radial axis, so there is more prevalence of radial femoral setup and less bifemoral. Importantly, in the top right corner, there is also less use of epicardial collaterals for retrograde crossing and more emphasis on SVGs. Success rates are increasing, and MACE rate encouragingly are stable. A couple of papers on gender differences in CTO-PCI, on the left from EuroCTO Club, on the right from Progress CTO Registry. 15 to 19% of cases are in women. They're usually anatomically easier CTOs, and as such, they're associated with higher success rates, but at the same time, also higher risk for complication and perforation in general and overall MACE. A paper on LAST in ADR cases. In Progress CTO, 11% of cases are usually are counterintuitively recanalized with LAST. On multivariable analysis, LAST was associated with less procedural success compared to other ADR technique. So if you really have to do it, as you can see here, it's better if you use it as a primary strategy compare if you use it like a bailout option in the purple column. A paper on minimalistic hybrid approach for CTO-PCI by Pier Francesco Agostoni, 143 CTO-PCIs, JCTO score on average 2.6, very high success rate, 94%. Almost half of the cases were recanalized with the blind antegrade wiring technique, and 2/3 were completed with just one guide. 97% through a 4-arm approach, either radial or ulnar or combinations, and 78% with 6 French sheaths. Interesting paper now, still again from Progress CTO about the impact of BMI in this procedure. We can see that in Progress currently 50% almost of patients are obese with a BMI more than 30. And in this patient, technical success is lower, and these associations remain significant even after multivariable analysis. So if you are obese, you have lower likelihood of success, probably due also to image quality issues. A paper on proximal cap ambiguity from Progress CTO, present in about 1/3 of cases, more need for move the cap techniques, higher utilization of retrograde, worse procedural metrics, higher incidence of MACE, and lower success rates. Another interesting paper here on the sacrifice of SVG after CTO-PCI. 2/3 of cases were in setting of recurrent SVG failure. SVG occlusion was achieved in most cases in almost 70% of cases with coils and the remainder with vascular plugs. All procedures were successful in occluding the graft, and importantly, at almost 1 year median follow-up, the incidence of TLF due to restenosis was just 5.4%, which is very, very encouraging because sometimes we are hesitant to occlude this graft after CTO-PCI because then we would not have any other conduit to recanalize these vessels. Interesting data again from Progress about the outcomes of CTO-PCI in previously failed cases. Of course, higher JCTO score, lower success rate, but only a 2% point difference between first attempts and subsequent attempt, no differences in in-hospital MACE, and importantly, the last figure on the lower right panel shows that we are more successful if these procedures are performed by a higher volume operator with more than 30 cases a year. Another paper on the prevalence of distal vessel of poor quality in 1/3 of cases in CTO-PCI, lower procedural and technical success, worse procedural metrics, lower use of ADR, higher need to use the retrograde approach, and high risk of MACE and perforations altogether. Another paper from Progress on mortality in about 13,000 patients, 0.4 mortality. This patient had more comorbidities, higher anatomic and complication risk scores, higher use of retrograde crossing as a first crossing strategy. Death was, in most cases, 83% cardiac in nature, and in more than half of the cases was due to tamponade. Canadian Multicenter CTO Registry, 1,600 patients, more than 10 years follow-up. Patients that were treated with revascularization, either PCI or CABG, did better with lower mortality. This association remained significant even after multivariable analysis. And also patients with revascularization suffered lower incidence of need for subsequent revascularization and ACS on follow-up. Let's now move on to this second section, risk scores and CTO program issues. So I think one of the most relevant publications in this space in the last 12 months was the paper from Progress on the Progress CTO complication score. You can see there are complication risk models for MACE, death, pericardiocentesis, and acute MI with very good discriminatory capability. And in particular, the MACE risk score uses age, calcification, blunt stump ADR, retrograde, and female sex as predictors. We validated this in the Open CTO registry, where more or less the area under the curve were maintained as in the original paper for MACE mortality pericardiocentesis, but it was actually much lower for acute MI, probably due to differences in the definition of acute MI in the two registries. Calibration was good for MACE and mortality, whereas the models underestimated the risk of pericardiocentesis and acute MI in the Progress CTO cohort. Very provoking data on the outcomes depending on the operator volume. So only 1/3 of operators in Progress does more than 60 cases a year, and these were considered high volume operators. And they showed again and again, this is not the first paper that shows this, the cases performed by high volume operators were more complex, but also more successful, and also a little bit more MACE, because these patients are also higher risk. Another study on single versus multiple operator CTO PCI program. In most cases in Progress, 85%, the program was a single operator program, and these operators tackle more complex cases, but the success rates and MACE rates were actually similar. And according to the Progress CTO score, anatomic complexity, in this patient with higher procedural complexity, the single operator program were a bit more successful. But I want to draw your attention also on the median annual CTO-PCI volume that for both single and multi-operator was not very high, 45 or 25 to 35 for multi-operator programs. So it's very important that we achieve proficiency by doing more and more cases. More data on same-day discharge after CTO-PCI has been growing from 3% 8 years ago to 21%. If we go radial only, we have this is the strongest predictor of being able to discharge a patient the same day, whereas more complex procedure, as described by the increase in procedural time, this was a predictor of overnight observation. Importantly, only 0.4%, so 2 patients suffer complication after discharge in the same day discharge. So this is a feasible strategy, provided that we have mostly a radial procedure with no complication, and we actually do this in more than 50% of cases in our practice. New stuff on techniques, new catheter from Terumo, from Japan, Ante-Owl, WR IVUS. This is a high-resolution IVUS coupled with a new wire that is only available in Japan called Conquest Pro 12 sharpened tip. As you can see here in the B and C panel up there, you can differentiate if you're seeing just the shaft of the wire or the tip of the wire, and this wire is so stiff that it can actually re-enter apparently also in the CTO body, unlike the Stingray. Just one case, we'll see. More data and more techniques. Redefinition, what is the Carlino technique? that is used in CTO-PCI to modify the plaque and the cap, to provide information or gear localization within the vessel architecture and clarify proximal cap ambiguity. Retrograde Carlino technique from a group of multi-center registry here. Very complex occlusion with a JCTO score on average 3.3. Most common indication is understanding the anatomy or clarifying gear location and for impenetrable distal cap. Overall success rate was high, 86%. 70% of cases were recanalized with reverse cart, and no complications were attributed to the Carlino technique. Another interesting tweak of an already published technique is this facilitated stingray-based ADR across distal grafted anastomosis. As you can see there in panel E, this is a particularly challenging scenario. We have a balloon that acts as a target advanced from the SVG into the native vessel. It's inflated. The Diastatic XS20 is used to stab towards the balloon. Then we deflate the balloon, advance the wire into the native artery. We use the same balloon to pin the wire and forcefully push the microcatheter through, and then we complete the case. More provoking data from Japan about drug-eluting balloons in cases that were mostly recanalized, 92% with anterograde or retrograde wiring. Easy CTOs with a JCTO score on average 1.7. Very encouraging follow-up angiographic data with late lumen loss of minus 0.15, and actually 60% of cases were observed to have had late luminal enlargement. On follow-up at 29 months showed a TLR rate of 14%. And so although they're not available for coronary use in the US, we can speculate that DEB can be used in ISR CTO or short CTO with stent-like result after POBA, hybrid strategy with DEB and DES, and DEB would be used for negatively remodeled vessel distally to in areas where we cannot stent, or as an adjunct in investment procedure. And finalizing miscellaneous topics, Invest CTO study that is randomizing, actually is including patients, is a prospective single-arm international multi-center study testing this approach of upfront SPAM or subminimal plaque modification in high-risk CTOs that are subsequently blurred back at 8 to 12 weeks, and then the procedure is performed for stage stenting. The co-primary endpoints are procedural success after both procedure and a composite safety endpoint at 30 days after completion of CTO-PCI. This study has been run in Norway and the UK. Scant data, but it's now available about the role of CTO-PCI in heart transplant recipient. This is a small series we conducted at the University of Washington. These patients are asymptomatic, so the only goal here should not be to improve the symptoms, of course. It's to extend the graft survival. It's very important to use invasive hemodynamics to characterize these patients that sometimes have subclinical heart failure, and the techniques are the same as we use in CTO-PCI in all comers. And the last couple studies, this one is an Italian study on the role of CMR with a dobutamine viability assessment protocol. Couple of messages. Collateral extent is not a predictor of viability. There are cases with no collaterals and a lot of viability, cases with a lot of collaterals and no viability. Interestingly, the traditional cutoff of LG transmurality of 50% does not predict patients who really have viability or not, because if we stress this patient with dobutamine, even up to thicknesses of 75% of LGE, we'll still have very high likelihood of viability. And finally, this is a study on the changes in coronary absolute blood flow, microvascular resistance, and FFR after CTO-PCI. There is an increase compared to immediately after the recanalization to 3-month follow-up in this coronary blood flow and a reduction in microvascular resistance. And patient characteristics and comorbidities have a stronger influence than procedural factor like crossing techniques on the absolute change in flow. And this is all I have. It was a lot, but hope to have packed not too many data in just 10 minutes.
Okay, thank you very much. That was a very comprehensive whirlwind review with lots that we could get into there. I think at the beginning of your presentation, one thing that came up was what are some general trends and changes in practice over time in CTO PCI. So maybe we can talk to our panel if, as individual operators, I think generally speaking, I really believe you need to be competent in all areas of access and all the various techniques, but any personal shifts in your practice over the last few years, maybe Darshan or? Yeah, sure. Go ahead.
So, so I think, of course, we, as we talked about before too, I think the most important technique that has to be advanced in the field of CTO PCI, in my opinion, has to be in the dissection reentry space. Either it has to be antegrade dissection reentry or retrograde dissection reentry. For me, myself, when I was in my fellowship, I actually, at the end of my fellowship, I actually realized that I wanted to do more ADR cases and more STAR cases. And so we had discussion with Manas, I want to do more ADR. And so many times we had good retrograde options, but still I wanted to practice more ADR. So ADR is going to be, I started doing more ADRs in those cases. And I think with hopefully the Triumph catheter is going to be some answer to the ADR. The other thing is, one thing that we have also tried improving the success of the ADR is attaching the Stingray balloon to the penumbra catheter, or getting another microcatheter and attaching it to the penumbra catheter and reducing the intramural hematoma, and that has made Stingray and re-entry easier.
Yeah, just an update. Triumph's not going to exist for 1 to 2 years. There was some, in the transition to Teleflex, some challenges in making the product that have significantly delayed its coming to market. So if anybody's waiting for it, you better learn some other new techniques. I think it was a great presentation of a lot of the data that goes on out there. I think, unfortunately, what you also see is a lot of self-informed data that, when we're looking at registries, it's really reflecting what people are doing, not necessarily what people need to be learning. And so I think what Salman said, I would just echo is, you're going to build your own narrative if you keep doing what you're always doing. And the important thing is to embrace fear and to embrace complications and to embrace the vulnerability of I don't know, and look at what you're not doing and figure out how to do purposely practice to build that skill set. And that's why you see a lot of antegrade wire continues to be antegrade wire, because nobody's trying to learn another skill set. So it's really important to figure out how to learn their skill sets. Darshan, we have 2 minutes. Talk to me about learning new skill sets and what advice you might give people about how to challenge yourself in that.
Yeah, so I think that Bill has been a proponent, as Kate has, and so has Lorenzo, specifically on purposeful practice. So figuring out what you're not particularly good at and trying to do that in a very controlled fashion. So to dovetail from what Salman said, if there are things that you don't feel that you're particularly good at, so for instance, if you have great retrograde collaterals and you could probably solve it retrograde, but ADR is something that you need to work on, you're going to try to do more ADR cases. And so, again, I think just identify a few things that you think you could be better at, and then start to do that in a very controlled fashion. Again, things like cart, which people know how to do reverse cart, but Godel cart has not been utilized as much for a variety of reasons. So if you want to practice cart, vein grafts are a perfect place to do that. If you're going to learn coiling, vein grafts are a perfect place to do that. So figure out what you're not great at and force yourself to continually do it, and then also seek mentorship. So the other part that I think that we do is, we're going to try to learn a lot of these skills on our own, maybe look at the videos that Manos is kind enough to put up. But one of the things is to get coaching as well. So if you look at a guy like Roger Nadal, one of the singular best tennis players in the world, he has a coach. Is this coach better than him in one-on-one play? Probably not. But at least that person can identify strengths and weaknesses that you may have that may help you to identify them and then work on them in a purposeful way.
That's very well put. I think we'll move on to our next speaker. So Srini Potluri is going to present us a case now.
Thank you. thanks to the CVI directors for giving me the opportunity to present this case on the panel. This is a CTO PCI. It's not always what you think it's going to be. That's our hospital, Baylor Scott & White, the heart hospital in Plano. So the patient is a 63-year-old male with history of coronary artery disease, bypass surgery around 9 years prior to presentation. He started having class 3 angina 4 weeks prior to presentation. Nucleus stress test showed infralateral ischemia. And the cath from outside hospital showed Lima to LAD was patent, and vein graft to the OM was a nub, it's occluded. And this is the angiogram. So the left circumflex is occluded, and you can see the OM that barely fills through collaterals. Right there. LAD is occluded, obviously, and the Lima to LAD was patent. There was a Rima to the PDA. That gives collateral to that circ distribution. So they, in the outside hospital, they tried to go through that left circumflex CTO. They were unsuccessful, and they said, well, we'll treat you medically, and they eventually sent that patient to me a few months later. So CTO mid-circumflex to a medium-sized OM in a patient with severe symptoms and on medications. They attempted to try to fix it, and it didn't work. And we don't know what the native coronary anatomy other than what we are seeing, that OM branch. So I brought him for the CTO intervention. I put a guide in the left main, and then IM catheter in the Rima to the RCA, expecting to see a lot of collaterals from the RCA into that OM territory. So this is the images when I brought him back to fix. So I'm injecting in the Rima to the RCA. Didn't see much in the circ territory, and then I injected into the native, and then I saw that OM branch filling. So my target was to try fix that into that OM branch. So when the crossing wasn't as hard as I thought it was going to be, I got my workhorse into the circ, and then got my microcatheter there, and tried a Fielder, didn't go through. Tried a Gladius Mongo, didn't go through. Tried a Gaia that went through, and then workhorse back, and then got the microcatheter all the way down, and injected through the microcatheter. At this point, I got Ivacin because I felt that that OM is too small for the amount of ischemia and symptoms. I don't know if you all noticed there on the IVUS. Certainly the OM to the circ, there was a big gradient, and if you notice, there was a branch you could see. So I did after I ballooned, I did an antigrade injection, and then I suddenly saw this huge circ that showed up, and then the vein graft was actually going to that distal OM and not the proximal OM. So I used a dual lumen catheter to get into the branch, and it was all true to true lumen and then proceeded with intervention from there. That the final angiogram stented from the OM into the circ, and then stented the distal OM or the circ by itself, and so that's what we use, dual lumen catheter to go across and fix the shock wave and DES. So then I'm like, yeah, we should have looked at the previous angiogram from 10 years ago, and we got hold of that and looked at the angiogram from before, which so this is before his bypass surgery. The LAD is severely diseased and gives collaterals to the RCA. And here you could see that huge distal circ and distal OM branches. So, a small to medium-sized OM with significant symptoms, moderate to large inferior lateral ischemia, should raise the suspicion of, is there something else we're missing? And then always try to find an angiogram from before bypass to establish native anatomy. I mean, based on the IVUS, I was suspecting that we have a big branch that we're missing, and we were able to find it. Thank you.
Thank you very much. It's a wonderful case. So as you mentioned, of course, the importance of getting those old films is really critical if you happen to have them available. In the absence of that, have you had any experience using CT to help resolve these cases? Have you found that helpful, not helpful, or no access?
Well, I think the IVUS really helped me figure out that there's a big branch coming off at that, and I could see that on the IVUS. Once I saw the IVUS, I was like already looking for, if I need to get there, and that's where, that's how I did the antegrade injection rather than just stent it right away. So.
Yeah, I would just say that at our institution, we make sure that we get all the prior films. We are somewhat dogmatic about this so that you know exactly what you need to tackle, particularly in post-graft anatomy. It can be a little bit distorted, and even films that are done from the outside may not necessarily be the most advantageous. The other thing is we do heavily use CT as well to sort of delineate certain things. So for instance, if your strategy worked out pretty well, but if you wanted to go, if you didn't know that there was a vein graft that went to that distal OM, that could be utilized as a conduit, maybe increase your chances that way too. So really want to make sure you know the anatomy exceptionally well if you can.
That's a great point about this.
Jason, do you want to talk about using occluded vein grafts to figure things out? I mean, would that have been an option here, you think?
Well, I think it would be. And in a case like this, pre-procedural planning is everything. You've got a diagnostic angiogram that's zoomed in, and panning, so you're not seeing everything. But if you've got an occluded right coronary artery and an open graft to it, and it's only supplying a PDA, that you've got a co-dominant system. So it's really incumbent on you to find exactly what your target's going to be. And again, like you mentioned before, making sure you get cabbage angiograms is certainly helpful. But in a case like this, when a gentleman's just recently developed symptoms and the target's the circumflex, that graft went down relatively quickly, using an old vein graft that's occluded can be extremely efficient and very safe way to get retrograde in this case. Now, fortunately, by the time he got to you, he had developed more collaterals, he had a better target, he had something that was, treatable with antegrade wire escalation. But I think from a safety perspective, from an efficiency perspective, you may have actually been a little bit safer and quicker going retrograde down the vein graft. Antegrade wiring with penetrating wires in a post-cabbage patient in the AV groove circumflex always makes me a little nervous.
That was the plan. If I couldn't get through with the antegrade, the plan was to use the vein graft. But Just for the panel, how often are you doing pre-planning CTs for CTO intervention?
Sure, I was just thinking about that. We actually don't use it a lot unless folks have had multiple bypass surgeries or we've already kind of failed the first time and going back. In part, that's just geographically people are coming from far away and it might require another trip. I think some of the keys are actually going down and looking at it with the radiologist and having someone who reads cardiac and can help you there. But I think this is a great point also. Like, we don't really do a lot of IVUS-guided puncture. I haven't found that to be particularly useful. We keep looking for the right cases, but I think where IVUS can really help you is just what you saw when you see the step up and you get a sense. So the CT would have told you there's something down there, but you still have to go find it. And in a post-CABG circ, that's still really challenging. So we need other ways to deal with ambiguity, whether that's, getting a knuckle going retrograde, and kind of all the things you talked about.
There was a randomized controlled trial called the CT-CTO trial, specifically looking at the use of CT, and there are two main conclusions. One, if you have a JCTO score of 2 or higher, then your success rate went up about 10 percentage points if you use CT. And 2, it also sped up the procedure. That is also accurate.
I want to add one point about the CT scans. We actually do CT scans on all the failures, the prior failures, or even the failures from the outside hospital. We tend to do a CT scan before we bring them to the lab. And there have been many times where our complete strategy has changed completely based on the results of the CT scans, so especially prior failures. Or if we fail a CTO, then we would do a CT scan, see if there's another approach that we can take.
I think at the end of the day, it's important to avail of whatever resources you have available to help you resolve the ambiguity in the case, and go with whatever skill set helps you resolve that if that's at your disposal, or if you do have CT or old films, just make sure you've got that information. So I think we'll move on to our next case now. Thank you so much. So next up, we have Paul Poommipanit to present our second case.
Thank you. I'm going to try and go through this pretty quickly so we can talk about this. So this is a 46-year-old female. She has a history of coronary artery bypass grafting, LAD endarterectomy with a lima to the LAD, radial artery to the obtuse marginal artery about 9 months ago. Came in with an abnormal non-invasive stress test with an ejection fraction of 35 to 40%. When I talked to her a little bit more in clinic, she said she never really felt quite right since bypass surgery, and I think you'll understand why as we go along. So this is her diagnostic cath, done at an outside hospital. LAD is completely occluded, the circ is completely occluded. The right has disease that's going to get addressed, and she's got collaterals from right to the LAD. This is her lima, and on the right is her radial to the OM. And so this patient got referred, the benefit of having a multidisciplinary meeting at our institution every week is that we learn things. So I kind of thought with an LAD endarterectomy, they just split the vessel open, they take the plaque out, and they magically sew it back up, and it's all good. But what they've told me is that they actually put a patch on it, they enlarge the vessel, and then they plug the lima into the LAD. So it becomes much more of a issue when you're trying to fix this vessel. So fix the right first, and then went after the LAD. And in any case, when you're worried about whether you can get across or not, like a good attending, I gave the wire up to my fellow. He wired this in about 3 minutes with an intermediate weight jacketed wire. And then we run into, what do we do from here? So this is an IVUS image on the right, and obviously the wire's on the left. And what you can see is that as we pull back, you can see that there's this just huge vessel in the middle where they did the endarterectomy. Distal vessel is about 2.5. The proximal vessel is about 3.0 to 3.5. So I guess my question is, how do I fix this? And I don't know. I don't know the answer. Do I try to taper this? Do I try to oppose this? You know, it's going to be a 5-0 vessel in the middle. It's going to look like a big sausage. I don't know. Has anybody done anything like this?
So one, the first thing is you're fairly lucky you got this quickly. Most endarterectomies just scar up and you have no tissue planes. Matter of fact, my experience with, if the surgeon says they're going to do an endarterectomy, I usually beg them to not do the surgery because the outcomes, there's actually, other than the Cleveland Clinic experience, which is single center, basically single operator, nobody's able to reproduce it, mostly because they don't do it very much. I would just, that's number one. Number two, this often is scar tissue, so it's fibrotic. So you end up having to do, a laser tends to be, if you can't get things across, very important. And three, I think you have to realize is, yes, the distal vessel right now is 2.5 by IVUS, but if you look at the glossy data and some of the follow-up data, it's at least a 3.5 down the road. So I'm not sure you need to make it a 5.0 where the patch angioplasty is, but you're going to need, and you can be reasonably aggressive about sizing it on both sides, in my opinion. And nobody has a ton of experience because most of these you can't cross because they're late.
Right.
And there's no planes to work.
Right.
Oh, sorry. I was just going to say a couple of other thoughts. I don't have a lot of experience with this either, but there's some stent platforms that have a wide range of expansion, so you can match them more to the distal vessel and then pot them quite large proximally. So you can think about that. You can also do potentially a staged optimization procedure once the vessel has remodeled. And earlier it was mentioned about drug-coated balloons, which I'm lucky enough to have at my disposal in Canada. So whether there could be a role there for treating some of the more distal disease with that, and you know, coming back even and having another look. So.
Yeah. And I'll make one more question. It's everybody in this room has got to stop worrying about right or wrong. 99% of what you're going to do, there's no really good data. There's no good clinical information. You're going to make your best guess. And you've got to really become uncomfortable with, I'm making a good guess, rather than this is the correct decision. It's risk, benefit. It is not right and wrong.
So I made my best guess here in a diabetic patient. I dropped, I pre-dosed obviously more. I put a 2.5 and a 3.0 in, and then I posted with 3.0 and 3.5. Imaged it again. It actually looked pretty good to my eyeball, and this is my final, which is not bad, I thought. And so, you know, we kind of already addressed that question, you know, what do you do in these situations? And how big of a vessel do you go? How big do you expand it? So I decided to pick something in the middle as opposed to trying to get that vessel all the way out to 5.0 or 6.0. She did well, actually, for about a year, and then she presented with a non-STEMI. EF is better, 40 to 45%. Her cath essentially showed a high-grade distal RCA lesion as well as her LAD reoccluded. So had to go back in and try to tackle all this. So once again, fix the right first. And then reassuringly enough, you know, I couldn't get it across with an intermediate weight jacketed wire. So it was just a proximal cap issue. Once you puncture the proximal cap, everything just kind of flew down there. So ballooned it and then imaged it again. Most of the stent that I put in before actually looked okay. It just ended up being a proximal cap issue, which I guess I missed on imaging multiple times the first time, that you can see on the IVUS on the right. And so I wired the diag because I was worried about it. I went ahead and ballooned it with a 3.5 NC, put a 3.5 stent in, expanded this area here, imaged it again. I got an MSA of 4.5, which bothered me, so I ended up putting a IVL in, IVL'd it, and then took a 3.75 and went up to 30 atmospheres multiple times. Got an MSA of 6.6, and that's kind of where we are right now. So I don't have a lot of experience with LAD endarterectomy, but I don't know how she's going to do long term. And intravascular imaging in this particular case is kind of the key. Thank you.
So, quick note on imaging. You know, we talk all the time about the importance of imaging, the value of imaging, and it seems like every time I go to one of these talks, all I see is somebody using a kind of a low-frequency IVUS. And this is the type of case, particularly in yours, Paul, where you have stent failure, and I think you know, the old school IVUS just doesn't give you enough information. You couldn't see anything about your stent sizing within the stent. You can't see if there's evidence of stent fracture. Certainly, that's high on the list of a potential cause in a vessel that's been previously tacked down with a bypass graft. So, in a case like this with antegrade wire escalation, I think it's a great case for OCT because you're going to get a lot more information on your mechanism of stent failure, which may help tailor your therapy, or at a minimum, if you have done some dissection, I think a higher frequency IVUS is going to be a little more informative.
So that was in the age where OCT catheters were hard to find, even though we're a high volume OCT center. We didn't have rotational IVUS on the shelf because I guess we all used them all. So I needed to up the par on that. So I used what I had in that particular situation.
Thank you. So I think we'll move on to our next case. So our third case is Dr. Farouc Jaffer, presenting case.
Thanks, Alison. Thanks to the panel. And it's great to talk about this case. It's already been mentioned that CT might be of some value in certain complexity cases, and hopefully this one will share some of that where we found it to be useful. My disclosures. All right, so this gentleman, his pertinent history, he's 80 years old, had refractory angina post-CABG, 1992, so it was a long time ago, lima, and 2 veins that were occluded. He presented in the fall of last year, refractory angina, and was found to have severe aortic stenosis, as well as a patent lima, and patent circumflex stent, but an occluded right coronary and occluded diagonal, first diagonal that was large. He was ultimately referred for TAVR for the severe AS, but he remained with refractory angina, and so came back for additional PCI. It was a 2-step approach. We first looked at his right coronary as the first target. That improved him a little bit. He was still in the CCS class 3 category. So we said, let's evaluate what we have. So this is just pre and post on his right. I'll just see that there. Go back. Just to show his right was, that was completed as typical with the post-CABG case. Diffuse, calcific, intense coronary disease. And I'll just show that one more time here just for the completion's sake, but it doesn't matter if it doesn't play. Okay, there it goes. So right was fine, not providing collaterals to the diagonal. We didn't expect that, but just it was good to have that vetted. So we said, okay, let's go on and evaluate what we have. And this is a diagonal that is filled via the lima with a large epicardial collateral. The proximal cap is a bit ambiguous. You can see there's a proximal LAD occlusion. It's not entirely clear where that diagonal comes off of and what the course is. So this is really a great time to consider whether or not we have advanced imaging modalities that can help us. We often use IVUS for resolving the proximal cap, but in this case, the LAD itself is not open, so it'd be hard to really identify D1. So in this case, we're thinking about CT. And so he remained limited on maximal therapy. This was a relatively complicated diagonal in the sense of it was ambiguous at the both proximal and distal caps. There was some suggestion that it was long and calcified, as well as potentially ambiguous in both dimensions. So maybe for the panel, these are limited views, and but perhaps just curious if there's a preference for an antegrade approach or a primary retrograde approach. Any comments for that? I know that epicardial looks really tempting.
Thank you. What would you
We'll probably base this. In my center, we don't have CT to really investigate that. So antegrade approach for me, and we're not doing much epicardials. So we'll do antegrade with base technique to get around the ambiguity.
So Salman, if he goes antegrade, what's the dismount? Say it does an antegrade wire.
Yeah, I mean, the proximal cap is ambiguous. The distal cap is ambiguous. We don't have a vessel. I mean, usually if there's a vessel, we can try to side base and maybe try to enter into the diagonal. I think at this time, we don't have an IVUS-guided puncture. That may not be that probably doesn't look like it's going to be possible. So I think for this is either I agree with Ankur, either base it or resolve the proximal cap ambiguity there, or the second approach is going to be retrograde. Looks great, retrograde option. I wouldn't definitely try it in the first three months of my practice at all, but the mid segment of the epicardial looks a little tortuous, and that just so that's a point of concern for me, the epicardial, the mid segment.
Great. Yeah. So it's a challenging situation here. We looked at some of those aspects. Base is challenging because it's a very short zone, and it's going to be hard to advance that balloon and secure it. We were generally comfortable with starting with jacketed wires to see if we could probe the actual proximal cap zone. But before I get into that, I just wanted to talk about how CT guidance can really help with CTO PCI. We talk about it a lot. Darsh mentioned the clinical trial, and Bill mentioned some of those limitations, but in general, we can't see the segment that is occluded on angiography, and CT certainly can. So you get information about angles, bifurcations, ambiguity can get resolved for the proximal cap, the vessel course, and the distal cap. It also helps you not underestimate calcium. CT is, of course, fantastic for that. And there's times where it really can help clarify non-diagnostic angiography. How many times have we seen a post-CABG patient not have their native right shot for years and years and years, and you don't know if it's flush occluded? That can affect how you're going to approach some of those cases. So CT is great for that. And then there's ways to use it beyond just pre-planning. You can actually use it in real time with certain software to fuse it on board. So this was helpful for us as we were starting, because I really had no idea of where that D1 was going to start. We did take a jacketed wire with a Pilot 200 and stopped after we didn't feel comfortable. You can see on the right the segmentation of the CT. This is just a still frame. This is really great, right? We actually see where the LAD, the circumflex, and the D1 run. The D1 is challenging, and there's a big loop in there. And I said, boy, I know my wire seems to be going in the right direction on that Pilot 200, but am I really going to push it right there? Even though we had some CT guidance, I paused and I said, I'm not exactly sure I want to keep going in this direction, and I definitely did not want to take a stiff wire at this time because I did not understand that loop. So I can probably I'll just skip to this part. But so our next approach was to really then look at that epicardial, because otherwise I felt like we were going to stall or do something that was higher risk. Taking a stiff wire in an ambiguous zone is the last thing that I really want to do. So we said, let's see how the epicardial can probe, and this was ultimately crossed with a Caravel supporting first a Suo, but that didn't really progress. Ultimately, a Xi'an Black was able to navigate some of those curves, and the microcatheter Caravel followed. We got to the distal cap, and you can see there, we've injected and we're filling it. No evidence of injury or harm to the collateral at this point. But we're stalling with that proximal cap, that distal cap. And you can see that there's contrast maybe going a little bit north of the collateral and then something going off to the right. Any comments about what's happening right there? It's a little hard to see. Of course, I have all the prior information, but like what was happening there is that, and this took a little time, but the CT was helpful, is that this actually, as we pushed wires further and further, we actually realized we were going up the vein graft. And what happens, of course, is especially as these grafts age, is there can be so much tenting. What's actually going off to the right is actually the native target. So, we started to, and I didn't show this picture, but we actually deviated and were able to redirect wires retrograde to get a little progress to the distal cap and go up and over, but then we stalled, even with Carlinos and pretty stiff, aggressive maneuvering. Could not make it, partially because there was a big curve in that Caravel catheter, and it was getting hard. So we said, we're going to come back to antegrade. And this time, and you can see this is a real-time CT fusion. You can see that hook now lining up exactly with the proximal microcatheter, and it looks straight. So now, to me, this was a much more resolved situation. That hook was resolved by the retrograde microcatheter getting into at least the distal cap. So we said, now we're going to come in antegrade and come in harder. And so what we did is intensified guys and Hornets. Ultimately, in the Stato 20 made substantial enough penetration along the CT fusion axis, allowing us to knuckle and then ultimately do a standard reverse cart. So I found it particularly useful right in that moment. Ultimately, that led to being able to use a tip-in. We did not want to externalize across that very large tortuous epicardial. And then that allowed us to then place the antegrade wire and then stent with 2 stents without a perforation. And so just to, again, reflect on where CT was helpful in really all parts of this case, both on the proximal cap side, the distal cap side, and the vessel course. And having it in real time in this particular case was useful. So thanks very much, and happy to hear anything. Thanks.
Thank you so much. That was an extremely challenging case, and I can see that I certainly would have started to stall there with once you came retrograde, knowing where to go in an antegrade direction in the absence of that CT guidance. Any other suggestions from the panel? Kate, any other ways you would have tackled things?
Yeah, I was just thinking about all the things that make me nervous at the start of that case, so congrats for getting through that. But it is one of those where we were just whispering to Darshan, when you're getting going antegrade, you're almost just assuming like you'll get going down the LAD, and because of the tenting and a high takeoff, it's going to be hard to find the diag. So knuckle redirects can be challenging there, but trying to get a big knuckle going, I think this is where an interlegional Carlino can sometimes help just identify where some of the takeoff is. But if you're really ambiguous, then you have to try to solve something retrograde. And post-cabbage cases, that's exactly what I'm most fearful of, is that if you're just up the graft and you have ambiguity both directions. But I think that is a space where in the last few years we've tried to do more tip injections if we can't solve that, which obviously you were able to do other ways.
Jason, you're on a lot of CTO events. There's often a lot of discussion about not using epicardials, and there's concerns about different techniques trying to get out of doing that. What is your thought about the purposeful practice of, obviously this is skilled operators who've got experience. What do you tell people? Should people go learn to do epicardials? Is that an important skill set in CTO PCI?
Well, I think having a whole repertoire of techniques is certainly helpful, but you're not going to take on a case like Farouc just took on probably in your first 10 or even 50 retrograde cases. And so, we always talk about the importance of the retrograde approach to improve overall success rates. This has been shown for over a decade now that retrograde operators can consistently get success rates over 90% compared to those who don't have that as part of their tool bag. But it's really important to understand the difference between an epicardial collateral and other collaterals, and that these do potentially come with a higher rate of complications and risk. Now, somebody like Farouc, who's obviously got great imaging skills and great CTO skills, can take on a case like this relatively routinely. But if you're in your formative years and still learning CTO PCI, I think it's incredibly important to start your retrograde learning kind of more intentionally with safer approaches, such as open vein grafts to fix a CTO and using it retrograde, or using a closed vein graft, or using a septal perforator that's very relatively straight and safer, so that you get the steps of doing a retrograde. So when you do have to do that higher risk epicardial, you're able to do it with a little more efficiency and potentially with a little more safety and ability to get yourself out of trouble if you get into trouble.
It's a Farouc, you're an experienced operator. It's an amazing case. A lot of discussion about don't go down Limas to do retrogrades. A lot of discussion to not use epicardials. What's your mindset when you're doing it? How much internal emotional dialogue are you having so that people understand out there that there's an emotional piece in doing this as well as a technical piece?
No, thanks, and I appreciate all the comments. Definitely, I'm going to mention straight up that my heart rate was greater than the patient's at all times during that cross. So we don't take these types of cases for granted. One of the key aspects is programmatically. These patients are super well counseled over multiple visits to really understand the risks and the strategies we're going to take on and why we're taking that on. And he knew there was certainly a risk of any procedure on this vessel. So that always helps de-risk what I'm feeling at the time because we feel like we've really counseled the people well. The other thing that we do is the days before, we're just confirming all of our neurocoils are restocked. We're ready for kind of absolute complications. That also helps me, know that if I get into something that we have all the right equipment there. So that's a way to de-stress it. But, I think we're also willing to accept failure, right? Like if I'm having trouble crossing that epicardial collateral, while he has to live with class 3 angina, he's living. And so we're not going to do something super aggressive, and that just takes some pause and skill to reflect on and not worrying about your numbers and success rates and things like that. So trying to blend all of those and still get a good result is, hopefully the way we can do it safely.
Hi. Farouc was an amazing case. Did you consider maybe, in this case, I would maybe have tried to open up the LED. Your retrograde, if you had needed to go retrograde, it would have been a shorter retrograde because the CTO was short, and then afterward using the native to go through and then go in retrograde. I would have maybe considered that then using the Lima, which gives me always the chill, especially with that amount of potential ischemic territory. So I'm just wondering if you considered opening the LAD.
Yeah, there's two reasons to potentially think about wiring the LAD. One was to actually be able to then IVUS the side branch and maybe see it if you got a knuckle. I don't know how long that LAD lesion was. I don't think it was trivially short. It's also a 30-year-old graft, so I don't think it's a super short TO, but we would have had to be subintimal and probably spend time on that. So it was a calculated balance. That was a great point. I didn't really emphasize going through the Lima aspect. That's a huge deal. He had a normal EF. He had a normal right heart catheterization going in. Was one of the other reasons I was asked to do this case before he had his TAVR. I said, absolutely not. Am I going to be doing a case with severe AS in this situation? I said, he has a mortality benefit with severe AS. Just fix it, even if his angina is still there. We'll take care of it afterwards because I just didn't want to have an additional complication. So those are really important. We also map the abdominal pelvic organs to make sure that we can put in MCS as needed. Sometimes we have it go up front. If his EF was depressed, it would have been in up front just to avoid LAD strain.
Farouc, one question. There's this dynamic review, right? The dynamic roadmap not for this case, but in general. So that many people are saying, save your contrast, maybe you don't have to inject so much. Have you used it much in CTO? I know the panel actually, that's been discussed quite a bit. Have you used the dynamic roadmap much for your cases?
For the contrast-filled segment, I can see some value to it. I have typically been in the Siemens rooms because of the CT fusion cases, but happy to hear what the panel has experienced with that is.
One question, Farouc, I have is especially with the CT fusion technology, how readily is it available to other centers, and what has been your challenges? And I think that's what the most important factor that I would want to know.
Yeah, I think the biggest limitation is that the Siemens systems in general are not as highly represented across the U.S. or world as other vendors. Once you can use any CT, and it's kind of auto-extracted the center lines. My technologist, who's typically a post-college student, is able to kind of just refine a little bit of the segmentation in 10 to 15 minutes, and then I usually will look at it for about 2 to 4 minutes before I start the case. So it's really a low burden on me, and we've now done hundreds, so it's faster. But it's right now it's specific to the Siemens software. There's no reason why other companies can't incorporate it. It's just registering a 3D data set on top of the X-ray system. It's standard for other structural images that everybody does co-registration for.
Then one quick comment is that at the end of the day, we shouldn't forget about the patient. So if we are at a center where we tried and failed, or at a center where would not take on the case, should really consider referring the patient to a dedicated CTO operator who can take on the case instead of 4 anti-anginal therapies and still having chest pain.
That's an excellent point. I think in the interest of time, we'll move on to our next presenter. Thank you so much. So next up, we have Dr. Rhian Davies, who's going to show us her worst case of the year. Should be good.
Alrighty, in choosing this case, it turns out I had a few of these, but I figured we will start with this one. All right, my disclosures. Okay, so 74-year-old male with history of chest pressure on exertion, had some shortness of breath and some fatigue, pretty classic symptoms. He had a stress test done that showed significant ischemia down the anteroseptal and the inferior wall. LV was intact and cath was requested. So here's his diagnostic pictures. You'll see severe RCA in the prox to mid segment with epicardial collateral there, kind of supplying his LAD territory. Then on his left system here, he has severe prox circumflex extending into that mid second OM vessel. Ultimately, I had to meet with the surgeons. He was deemed a surgical candidate because of family reasons. He decided not to pursue surgery. He needed to get home to help his wife and his son, who was sick at the time. So we arranged inpatient PCI for his RCA and his circumflex. That went well. He was feeling good, but had some ongoing shortness of breath. So about a month and a half, 2 months later, we had him return for LAD CTO. And you can see here, this is my setup shot. I'd like to ask the panel kind of what your thoughts are for this. What would be your strategy?
Salman, do you want to comment?
So, of course, assessing the CTO, it's an ambiguous proximal cap. The occlusion length is maybe about 15, 20 millimeters. Distal vessel is good. There is a good epicardial connection. So I think really good options overall. I think a retrograde overall is a first option, but this is an epicardial, so I would think about it. One option is doing a side base, but again, this is probably an ostial LAD. So, but I think we are resolving the cap ambiguity again. I think my first option would be IVUS-guided puncture, get the IVUS in, and see if I can puncture it with a polymer jacketed wire under IVUS guidance. That'll be the first option. Then epicardial does look appealing, probably retrograde, second option, and third option, side base. That's how it's gonna work.
I did, but I didn't include it. I apologize. I do later. We will get to that. That's a great strategy, and I, in retrospect, wish I was not afraid. And this is where fear drove my decision. I was thinking this epicardial, you could drive a Mack truck on it, but I was afraid that I might perf him. And with that, that led me to do a similar strategy where I took IVUS into the circumflex and then kind of couldn't really see a whole lot for the proximal cap, but felt comfortable kind of following the calcium track. And I did antegrade wire escalation. But you can see in that the left angio that my wire was kind of not where good, but I thought, okay, let me set up for Stingray. You can see just on the still frame here, I was nowhere close to where I needed to be for to actually use the Stingray device. So I decided to, I don't know, this isn't working. I don't know how to click for.
I would take a pause right here.
Okay. Just want everybody to really hone in on the fact that I did not know what I was doing in this case. Okay. Okay, so here what I thought was, all right, let me remove the Stingray balloon because I wasn't able to bobsled it in because of that calcium that in the territory that I was. So I pre-dilated with a 1.5 balloon. What harm would a 1.5 balloon do? Well, when it's in a wrong spot, it does a lot of harm. And quickly the patient told me, Doc, I'm having some chest discomfort. And that's where, you start to get a little bit of chest discomfort yourself and things start to move a little bit quickly. I took an injection. You can see that there's clear dye extravasation flowing. And fortunately, I already had second access, so I removed the AL guide that was previously in the RCA and switched it out for ping pong guides. And did balloon tamponade, hoping that I could seal it. And you can see here clearly after about 10 minutes of holding on 2 occasions, it wasn't improving, if anything, getting worse. So I moved on to doing an emergent pericardiocentesis and ended up putting a 4026 papyrus from the left main into the circumflex. He subsequently was watched over about the next 72 hours. 24 hours later, he got the drain taken out. He was feeling okay, and I apologized for my decision-making and feeling like a terrible operator. I decided to see him in clinic. I know. It's therapeutic. So with that being said, I decided I needed to do this epicardial, but I still wasn't super comfortable. So I did what I tend to do is I seeked help, and I actually set up a couple cases and had Bill come out to my lab to tackle this with me. Not only have I not punctured through a covered stent, this is just something that hadn't been in my skill set before, mainly because I hadn't made a perforation to this extent before. So despite trying to talk to him about potentially even getting a robotic lima, the patient was like, no, I want you to open up my CTO. So we brought him back. This was about 3 months later. And very quickly was able to traverse with a workhorse wire down into the distal RCA, changed out for a SUO, and then advanced that up through the epicardial with a Pro XS 150. And at the site of the left main, was able to puncture back in with a Hornet 14 into the papyrus and then subsequently into the guide itself. And after that, it was straightforward IVUS-guided culotte tech procedure that stenting, and he had an optimal result. I will always highlight this algorithm paper for assessing when things aren't going well to kind of work through it in an algorithmic fashion. But for me, perforations can lead to quick hemodynamic collapse, so it's a matter of having your team prepared and being able to stabilize the patient. It requires you as the operator and the team to work coherently together and have horizontal communication. I emphasize closed loop communication. If you know where your tap kit is, you know where your coils are, those sorts of things before the procedure, this is always helpful to just try to streamline it. My staff was phenomenal during this case. But ultimately, I would always say that we have umpteen opportunities to continue to learn, but don't be afraid to ask for help. Thank you. That was a pilot originally, and then I switched out for a Mongo, and then that was where I kind of exited probably the vessel. Mm-hmm. It was stiff wire. Yeah, I got a branch. Mm-hmm. Yeah.
When you do pericardiocentesis in this kind of situation, do you do it with, and thankfully, this happens very rarely, that patient is flat, or do you sit them up a little bit? Just a setup of your pericardiocentesis in that situation.
I leave them in the position that they're in, and in this situation it was just subxiphoid, but Bill has taught us to do pericardiocentesis is using the Shiba needle technique, and he could probably describe it better than I, but if you have an accumulation that's developing, and to be safe so that you're not going in with like a large bore needle, you can put the Shiba needle through it to help guide that and to reduce trauma to the surrounding tissues. Do you want to?
Why is it when we get complications, everybody starts talking to me? So basically, we had a couple cases that the tap led to more problems than the original perf. And so it's because the needles are big. If you're doing subxiphoid, it's hard to get a micropuncture needle all the way there. It's hard to get a micropuncture sheath all the way there. So often you can't do it. It's also very difficult. Like I learned how to do all my taps originally transapically. So I'd relearn subxiphoid as I got into this. So we had a year where we had 2 people in the OR, and when we went to the OR, they had RV perfs from the pericardial needle. So my purposeful practice that year was I went and worked with our EP doc who does dry taps, and I learned how to do a dry tap. So she came, we took all the cancer patients, and we did taps together. I did a couple dry taps with her, and I got practiced enough at it in an elective situation that when it finally needed to, I did it in an emergent situation. Kate went through the same process. Rhian went through the same process. Our fellows go through the same process. And it's a very subtle, it's a rare event that happens, but it's just trying to make ourselves a little better. I think the other teaching points, since I'm aware of this case, is one, if you get into trouble in a CTO, bail. Too many people will keep trying. That was one of my purposeful practices from open CTOs. When you get a perf, quit. Lorenzo and I had a case earlier this year where getting the artery open actually ended up being the wrong thing to do because it actually ended up leading to the patient's demise. And so sometimes it's better to take your loss and walk. And the third one I would tell you is if you've done enough retrogrades, and Rhian has, and we talked about this, that's a case where you do purposeful practice. That is begging you to do this as a retrograde case, and you've got to overcome your internal fear, and you've got to overcome your institutional fear to do the purposeful practice. One, probably would have been better, and two, you've got to, you're going to build a narrative. If you avoid stuff, you'll just keep avoiding it. So you have to mentally look at what am I not doing and force yourself to do it. I don't know, Jason, do you want to make a comment about purposeful practice or those things?
Yeah, I think this is a great case, and you showed obviously you had the skill set to do it, but it was that fear that kind of got you into trouble. I think the other thing with this particular case is just when you have proximal cap ambiguity, there's ways we can try to solve it. We can do IVUS-guided cap puncture, you can try to get in subintimally proximally, but in a case like this where it's flush occluded, obviously you don't want to get subintimal in this guy's left main and then create 2 channels in his left main. So this is a case where it's very common to have these little tiny branches that come off. I know Stefan showed a case at our CTO course of this where it's real easy to puncture, and these jacketed wires are very safe if they're knuckled and they're in the architecture of the vessel, but where they cause perforations are at the end of vessels, and if you get into a tiny vessel, they're easy to perf. And so I think that's what this case kind of highlighted for me. I think from a purposeful practice kind of scenario, this is an epicardial. Yes, it is higher risk, but if you've done plenty of safer epicardial or safer retrograde cases through vein grafts, through easier septals, I think you build the skill set so you're going to be a lot safer in doing it when the time comes when you have a case like this where really that's probably going to want to be the upfront strategy you're going to want to use.
One more question. For your collat on the way back to the left main, did you have to put another covered stents? Or you were not afraid to reopen the perfect from the side branch?
No, it was fine at that point. Yeah, and this was about 2.5 months later, so we had a wire in the circumflex and then just finished with a final kissing and pot of the left main.
So we assumed I did the second case. I'll take, Rhian we were both worried about that, but it had been long enough. We didn't think it'd be an issue. But we were prepared if we needed to do culotte papyrus. I've done it. Unfortunately, I've done 4 now. 3 were elective, 1 was emergent. So we were prepared if we had to. But the assumption was if we went retrograde, punctured into the papyrus, that the tissue and everything would be sealed because it was probably a small branch that we'd exited.
Sure.
But it was done later, not in the same setting. And that's what I'm telling you.
3 months.
In the same setting, you really should try to get out of Dodge.
Just from a technical standpoint, the final kiss in the culotte main point in the left main, does that expand after the culotte or the covered stent's been there for a few months again?
Yeah.
Or the covered stent graft area doesn't expand anymore for the final kiss?
No, the papyrus actually opens very nicely. and is actually pretty easy to dilate the struts. And actually, a 2.5 papyrus can be made to go 6.0. They actually have a great expansion profile, so it's usually not a big deal to manage them after the fact. The one caveat would be the cells. You can only make the cell so big, and we just tried to make it as big as we could. Again, it's not trying to be perfect. It's just these are what you have to deal with to try and get a good job.
So just when it comes to fenestrating a papyrus, so our former fellow Shrikant Adu Sumali actually wrote the paper with Rustam on it. Because the papyrus is made of polyurethane, not PTFE, like the Graphmaster, it's much easier to fenestrate. So again, yeah, unfortunately, super easy sometimes.
Thank you very much, Rhian. Okay, our final speaker is My Best Case of the Year by Dr. Jaikirshan Khatri.
Thank you. Yeah, Jay Khatri is fine. So, I mean, along with the theme that has already been presented, this case is sort of like to highlight some of the emotional roller coaster that can happen during some of these cases and how you have to acknowledge that and deal with that because that's the only way to get some of these cases done. And so, without further ado, I'll share this case. So this is a 75-year-old woman with CCS3 angina. And a history of atrial fibrillation. She's had remote PCI, a couple of bare metal stents to the RCA, and subsequently had bypass surgery in 2006. In 2011, she had a cath that showed her graft to the LED was open, the vein graft to the RCA was open, and the grafts to the lateral wall were occluded. That was managed medically. And then more recently in 21, she presented with an acute coronary syndrome, and they ended up stenting vein graft to the RCA, which they thought was the culprit. That had subsequently gone down. She was cathed about a year ago. That graft was down. She has an RCA CTO that was being managed medically. And I brought this just to show you what she started with when she had her ACS. There was they thought that was the culprit, so they wired up and stented the graft to the right. And right here, there's a stent. There's a stent up here in the proximal right, and there's a stent right at the crux, just proximal to the crux, that has a trickle of flow in there. So this is a case that, I think that ideally, if it had been done in a dedicated CTO PCI center, maybe you would have stabilized this patient with balloon angioplasty and then come back and go through that graft and go retrograde and finish the CTO. But that's not what was done. She was managed medically, ended up having a fair bit of angina, and then came to see us, and was recathed by me the week before we did the procedure, and this is what the proximal right's got a stent in it with a trickle of flow in it. What was sort of changed here is that stent that I showed you before that had the trickle in it really doesn't have much flow in it at all anymore, so it's sort of like an unfortunate angle here on the crux to try to get in there. So looking at this, we kind of decided up front that we really wanted to be in the PL retrograde if we had to come retrograde to do the case rather than the PDA, so that we would have a more favorable angle to get the gear up and through the case. So I'll show you what happened. So we started with antegrade preparation of the CTO, and so this was just standard wire escalation, and we used a combination of wires and pretty quickly realized that we were okay in the proximal stents, but then we're kind of probably in no man's land more distally. So we just kind of left that gear in place and started to go retrograde. This is just a moving angel. You can see it's a little confusing because there's so many stents, but these are the stents in the vein graft. There's some stents back here that are in the RCA, and you can see we're not really tracking those stents anymore. So we just left that there and decided to come retrograde. So there's a couple of good septals to use. This first septal is really the one we wanted because we think that this one, through this channel, will go into the PL and give us a really good angle of attack on the distal cap. The second septal pretty much has a couple of connections to the PDA and no real access to the PL. And again, we talked about how the occluded vein graft also goes to the PDA, which would also give you that unfavorable angle. So what we really want to do is get into this one. But we weren't able to do it. No matter what we did, we tried with a Xi'an Black. We could never select anything other than the second septal. We could never get in the one that we wanted to get into. We tried it with a dual lumen microcatheter, but we couldn't even pass that into the LED because there was a lot of calcium in the LED. So we tried to rotablate this with a 1.5 burr, and that just would not cross. And she became profoundly bradycardic and hypotensive, so we had to resuscitate her. And then we started an aminophylline drip, and then burred out the LED with a 1.25 followed by a 1.5 burr. And we thought that, okay, now we have room. She's stable, we have room, now we can get in there. But no matter what we did, we still could not select out S1. So after all that work, so you had to fight this frustration of, I did all this work, I made her a little sick, and I still can't get it into the septal. So what we decided to do is like, look, we wasted a lot of time here. Maybe we should just try S2 and let's just see what happens. So that was sort of the next step. So we pretty quickly got retrograde by S2, did a tip injection through a microcatheter. We're really unable to wire the distal cap. What was kind of exciting and interesting is that there's still a trickle of flow now, which I wasn't able to see on my setup shots in that stent, but I could never make this corner. We tried it with a bunch of jacketed wires, couldn't do it, and then she had a VF arrest on the table. So we shocked her, resuscitated her, she was stable, we made several more attempts to try to get in here. We even tried to pass a dual lumen microcatheter retrograde, it wouldn't pass. We tried with an angled microcatheter, it didn't help. So now what? Do we give up and go home or try some more? So this is just some more shots of what we tried. So this is an angled supercross, could not make that turn. We tried to use the retrograde wire as a marker, so we put the retrograde wire in the PL, try to go antegrade again to try to redirect a steerable wire as just a marker approach, didn't work. So do you fight that frustration and keep working, and what do you do next? We decided that there's got to be a way to get this done. So we kept working, and this is literally failure mode. And just playing around and feeling like we have nothing else to lose, it just somehow, the wire found it, we somehow managed to find S1 after all of this. So got down into S1, and we did a tip injection through S1 to understand which way we wanted to go, and she got profoundly hypotensive, like almost needed CPR, so hypotensive. So we had to resuscitate her, paused, took a bunch of angios to make sure there were no complications, didn't see any major problems anywhere. She looked like there was no reasonable explanation for why this would have happened, but she stabilized. So then, you wipe that sweat off, change your shorts, and get back to work. And so we did this tip injection. It looks somewhat tortuous, but it doesn't look too bad. And it looks like it gives you what we want. We want to take this track into the PL so that we have a nice angle of attack. And so it took a combination of wires. It really wasn't that easy to do this, but eventually with XTR and the Rhian, we were able to get into the distal RCA via the PL branch. And so now we're feeling pretty good. So I started out with the Gladius bongo to set up just modify the distal cap, get a knuckle going, and the knuckle fractured. So I thought, okay, no big deal, the knuckle fractured, we can remove the wire. There's always this invisible part on these AC1 wires that's in there that's still retained in the microcatheter. So my idea now was like, let's take an 008 wire, let's take a bandit wire, we'll shove it down the microcatheter, and it'll push whatever's retained in the microcatheter out, and we could continue the case. So in the right panel, you'll see there's a bandit wire that I think is pushing the retained fragments of the wire that's broken out, and it's making a nice knuckle. So at this point, we set up reverse cart. We came down to antegrade with a guide extension and a balloon. And I said, I just want to swap out to a steerable wire. So I took the bandit out, and I put a Gladius back in to finish the case. So this is the reverse cart setup with the Gladius just waiting. And I try to drive the Gladius, and I can't torque it, I can't push it, I can't pull it. So now I'm starting to get pretty upset and kind of frustrated, but so. So now what do you do? So we're there, reverse cart's done, but the gear's stuck. Any thoughts on the panel? What would you guys do next?
So had you tried to was the Mongo fused with your Caravel?
Absolutely, 100% fused.
And was the Caravel still fused in the vessel? Or could you take everything out?
I could take it out.
Okay.
But it took me forever to get in.
That's what I would do, is take everything out. This lady's trying to tell you she doesn't want this procedure done today.
Yeah.
You've already done shocked her, almost did CPR, given her lots of doses of vasoactive drugs. I think she's telling you it's time to live to fight another day, especially when you've got retained gear. And I think I would at this point, abandon that retrograde approach, knowing at least now I can get it off safely. If I keep working, I may get everything fused down there, and then I've got a real problem.
Yeah. So we had all those discussions. The reverse cart's done. Literally, if I could steer this wire, we're done. So I said, there's got to be something more we can do here. So we decided to parallel wire the septal. So we left all this gear in place and took a second microcatheter with a wire down that septal. And what's interesting is when I did this, I pulled the first wire, and it actually dragged the retained wire out with it, which was really pretty fascinating. So on the left panel, you can see that's the Mongo I was trying to do the reverse cart with. This is the Mongo that I broke, and they both came out together, which was kind of cool. Not planned, but it worked. So now we basically started over again, and this time I just took a regular Xi'an, and the Xi'an just wired true to true because the reverse cart had already been done. So we went through the septal, and the Xi'an just went right across and towards the integrated guide. And then we finished the case. That was the final result in the RCA. There was a bunch of work to do on the left side, which we did next. So the total contrast was 180. The radiation was 1.7 gray, and it unfortunately took forever. It took me almost 6 hours to do this case, but it came out great at the end. But it really was sort of a testament to the team, just to kind of keep our cool. So one of the lessons I've learned from working at the clinic with a lot of much more senior partners is that, side branches that are tough to get, oftentimes rotational atherectomy is really what you need. You just need to debulk the main branch, and it creates the space to get into these side branches. So we do this a lot. So I think it's perfectly safe to judiciously continue your procedure, provided you've ruled out all the complications. And so far, she got really sick, but there was nothing wrong that we could see. There were no perfs, there was no effusions, there was no reason that we couldn't continue. And she, after she would recover from whatever had happened to her, she would say, I want you to continue. So, we kept going. So the operator fatigue and the emotional frustration, it's a real thing, and you have to try to acknowledge that and fight it as best you can. And for us, the way that we do that is we have a second operator that's available to help us out. Obviously, we have our advanced fellow to help us out. And it's critical to take advantage of that support system to try to get through cases like this, because that's the only way to keep your cool and get this sort of thing done. But in the end, she did great, and the result speaks for itself. So that concludes my presentation.
Jay, sir.
I'm not saying go ahead, Lorenzo.
Yeah, so Lorenzo was asking, could I have just used the retrograde gear as a marker to go integrate again? And I think that would have been perfectly fine to do. We'd already dissected that for the reverse cart, so we're probably floating in a space. But yeah, we could have done that. And we had tried that before. We tried to use the retrograde as a marker before and got lost. So we created all these tracks already from trying, so I wasn't sure if that would work.
My question is silly. It's not a question, it's a comment. Did you stop at the 7-Eleven to pick up a lotto? That's my only question.
Yeah.
After this case, you probably needed it.
Jay, quick question. Did you think about just maybe using the SVG and then using a supercross? You knew where the stent was that you had to look at and try to puncture through.
No, that's a great point. So I brought that up because I didn't really want to be in the PDA. My intent was always to try to be in the PL, because there's a stent right at the crux, and I would have had to make a sharp turn to get into it. And I didn't bring the pictures, but it was not a friendly proximal vein graft. It's like just a round oval. There's nothing there anymore, and there's a bunch of stents in there that are occluded. So I've not had a ton of luck with those, but I think anything's possible if you try. But it would have taken me into an unfavorable angle, which is what I was trying to avoid anyways.
You want the old guy coaching?
Sorry?
You want the old guy coaching or a patch on the back? So the comments are, one, Caravelle at times is not a great retrograde catheter because it's got a lot of tolerance issues. Two, when you get a wire fractured, you got to get all the equipment out. Don't try to push it out the end because the filament doesn't push out because the wires, there's a tolerance issue between the wires and the wall. 3, if you've crossed a collateral with a microcatheter, it's almost always going to be wired super easy again, so don't be afraid. It's like anything. If you got it there once, you're going to get there again. The third thing I would think about, this is a case for purposeful practice where actually doing CART might have had value. So taking a 3.0 or a 3.5 balloon across the bifurcation and come antegrade, and even if you're outside the stent antegrade, puncture back in and crush the stent, it really doesn't affect restenosis rates. So CART might have been another excellent option in this. And I will say as a general statement to the audience, yes, lots of things went wrong. Yes, it turned out really nice. It equally could have turned out really bad. And so it's really important in these cases is, could I bail out, right? When you had all the antegrade, you could have just ballooned antegrade, set up reverse CART, and said, you know what, we're gonna bring her back and do it another day because we have all these other things. I appreciate you can keep going, but also I would coach everybody, that mentality can get you also into a lot of trouble. So be very careful in the pregnant pause of keep working versus not keep working.
Thank you so much for your case. Yeah. All right, I think that concludes our session. Thank you so much to everybody.